Well, good afternoon, everybody. Great to talk with you as always. So this afternoon, we're pleased to have Dr. Sarah Sutton with us. As with several of our speakers, Susan Miller in our Colorado office has been a great connection point, actually cousins, so with Sarah and Susan. And Sarah reached out, Susan reached out to Sarah just about a month or so ago and said, hey, you're in this field. What might you be able to bring to the table? And so we've been talking a little bit. And so we're grateful to have her. So Dr. Sutton is an associate professor of medicine and antimicrobial stewardship director at the Division of Infectious Diseases at Northwestern. And she works with infectious diseases pharmacists and other hospital epidemiologists at the university as a professor or researcher, and has a really interesting infectious disease background, really focused on the kind of discussions that we're all having right now in terms of the vaccine and prioritization. So she has a background there, like many of our speakers who have particular expertise, be it in when we have insecurity or mental health and education and so forth, helping to give us sort of a lay of the land. What's the 101 that we need to be aware of, knowing that we're not going to be experts in all of these things, but kind of understanding the lay of the land of the field generally, and then getting into some of those specific conversations that are germane to today. Like the vaccine rollout and its implications on school reopening, some ways to think about that practically and ethically. And of course, here to give some contextual, some historical context, and also to answer questions, engage in conversation. So Sarah, I'm gonna turn it over to you, and again, welcome.
Thank you for the nice introduction.
All right, floor is yours. As always, folks, okay. Please enter your thoughts and comments, questions in the chat, and we will review them as we go.
Okay, I'm not sure I can move the slides myself yet, so if you could share, I think. No?
Can you, I'll move for you right now. Can you see my screen?
Sure I can. Okay.
Perfect.
Okay. So I like telling the story of the Mask of the Red Death, which was published by Edgar Allan Poe and published in 1842. And there's some lessons there from this, but it is actually a gruesome story. So Prospero is a rich nobleman. He invited 1,000 of his rich noble friends to hide out in an abbey away from an advancing deadly plague. And all of the people inside of the abbey, they're healthy. And guess what? They're bored and frustrated. And so he hosts a big masquerade ball to entertain his friends. But a stranger enters. He's dressed as in the costume of death, and he finds his way inside. So Prospero, in his attempt to confront the stranger, grabs him, and the costume falls, revealing total emptiness. There's nothingness there. There's an invisible enemy, right? What happens? Within minutes, he, Prospero, and the other partiers start dying from the rapid onset of the plague. So why do I like this gruesome story? Really, it reminds me that humanity has been trying to run away from plagues forever. We've had waves and waves of various pathogens, pandemics, plagues, whatever you want to call it, and humans have reacted in the same way that actually is somewhat effective. Well, we flee, we isolate, we deny, right? We ignore it. These are all things that humans do every time there's a plague, and that's what's happening now. That's what we see. But now, in recent history, we can vaccinate, and that really can change the outcome of plagues. So when I first agreed to do this talk, I wasn't sure of the topic that I would spin. What story would I tell? Well, it became very obvious that there was one really pressing story in the news, and that is, should COVID vaccination really delay school openings? I'm afraid I'm not going to give you the answer to that question because it's very, very complicated, but I can give you some ways that an infectious disease doctor thinks about this, and also some other viewpoints. So here's some very important people that have spoken about the concept of vaccination of teachers. So the CDC director and the CDC has said that vaccination of teachers is not a prerequisite to the safe reopening of schools. And they have good arguments that says that's okay, we can move forward. What does President Biden say? I think we should be vaccinating teachers. We should move them up in priority. And then what does the Chicago Teachers Union chief say? Well, he's not all that happy. Let me be clear. This plan is not what any of us deserve. Not us, not our students, not their families. The fact that CPS could not delay reopening a few short weeks to ramp up vaccinations and preparations in schools is a disgrace. So what was the upshot of schools, teachers, schools, and the teachers, and the city, and the government? For Chicago, they made teachers and janitors and administrators, made them 1B. So they are qualified to get the vaccine. The only problem is there's been a shortage. And hopefully that shortage is going to become less and less over time. There's still a shortage. So when one person gets the vaccine, it may be in place of another. So that's what we're dealing with. Next slide. So the objectives of my talk is multiple. So how do COVID vaccines really protect us? And what do we know and what don't we know? There's actually a lot of both. What about the bioethics? Who do we prioritize when there isn't enough vaccine to go around? We deal with this every day and at multiple levels, at government levels, at hospital levels, at community health centers, at public health. Then I'm going to go through 5 reasons why teachers and other school workers should be vaccinated. And then sometimes people forget, what about vaccinating children when we can, when we know more? And then finally, where does that leave you? You're the people who are helping make these decisions and to help operationalize decisions that are made. Next slide. And here's the model that you've seen on lots of news shows, right? It comes flying in. It's much more beautiful than my example here. This is the model of the COVID virion. So one copy, really, of the virion. And what is it? It's a teeny weeny package of genetic material covered in a protein coat. And what do you see on the outside of that? There are these little spikes, and that is the spike protein. And we know a lot about COVID, and we also know about the whole family of coronaviruses. And that is the way our body responds to and reacts to an infection with these viruses, this family of viruses, is by responding to that protein. And so we knew about that from studying SARS and studying MERS, these are and other coronaviruses. If we were going to design a vaccine, we would be utilizing that knowledge that we could attack the spike protein, use that information that we know about it, and create vaccines. And so all of the FDA approved vaccines and the ones near to the top really utilize that one aspect that we present somehow the spike protein to the human cell, and then the human immune system responds to the presence of that protein. The great thing is people don't get COVID infection from one little protein molecule, even if it's in high supply, even during a vaccination. We get minor side effects from that. So why do I have this picture of these two probably wise men stolen off the internet? And that is they're presenting. They're presenting some wealth, some special thing to the king. And in the same way, if I could pluck that red thing off, one of those red things off of that virion and stick it inside of a human cell, the human cell would then be able to start responding to that in many, many different ways. We call the response the immune system, but it's a system. It's cells and organs and chemicals that all work together to fight off this invader. In this case, the invader is a harmless protein that stimulates the immune system. It's not the virus. It can cause, in some ways, a mild infection, a carrier state where somebody has no symptoms, or it can be a deadly virus. Next slide. This is just the top of the heap for the United States of vaccines for COVID that we have. We have two that are fully available to us and approved by the FDA, and that's the Pfizer and the Moderna. And then this week, or in the next few days, Johnson & Johnson is going to be most likely approved. It's been found to be safe. The advisory boards is saying that can be utilized. And in other parts of the world, the AstraZeneca vaccine is also being used. What is the common theme of 1, 2, 3, 4 for these vaccines is they all take out the body by getting the body to make that protein and present it to the immune system so the immune system responds. Next slide. Oh yeah, that's my reminder. Here's a plug for vaccination. People ask me, which vaccine should I get? There's 3 or there's 4. Should I wait for Johnson & Johnson? Should I get Pfizer? Should I get the Moderna? So the one that you should take is the one that's available and offered to you as soon as possible, okay? Right now, we don't have a population that does better with this one or that one that really makes a difference. So really, if you're offered one, take it. Next slide. Okay, a little bit more. How do our COVID vaccines protect us? What do we really know, and what do we need to find out still? One, that these vaccines, the approved ones, reduce symptomatic COVID-19 disease. And that's what the FDA requires in order for it to be approved. We have 2+ vaccines right now that have met that threshold. And they're high efficacy, beyond what we imagine, what we hope for, quite effective. And they reduce severe disease and death. So some of the vaccines might be a little bit better about avoiding the sniffles or avoiding fever for 3 days, but the ultimate endpoint is keeping people out of the intensive care units, keeping people out of perhaps the hospital, and those are really good, solid endpoints, and our vaccines are doing that. So what's in the hope category? What do we have early evidence that suggests that our vaccine might be doing, or we're still actually just waiting? We need more time to find out. Well, do our vaccines reduce asymptomatic carriage? So with the people who carry a little bit of the virus in their nose, but they don't have any symptoms at all. Does that reduce the numbers or stop asymptomatic carriage? We don't know. Thus, we know, does being vaccinated reduce transmission? Those two are linked, aren't they? Does the immune system last? Does the protection last after a vaccine? So I'm asking people to remember, once they do get the vaccine, make sure they remember which kind they got, because one vaccine might be better than another, longer than another, and that story is unknown yet. We're going to have to find out. People may need booster shots later on. Know when you get your vaccine, what one you got. Remember that. Will our vaccines, combination of vaccine, lead to herd immunity? You've probably heard that word before, or that phrase before. Will it allow us to return to normal life? Will it end the pandemic? Really good questions. And that's certainly what we're working toward. Next slide. Next slide. There we go. Great. So bioethics. That's a field of medicine and philosophy that studies healthcare issues. We know a lot about how to deal with shortage because there's been shortage before. Maybe it wasn't a vaccine, maybe it was an organ transplant, maybe it was a dialysis machine, maybe it was access to a doctor. Lots of different decision-making when there's a shortage that happens. So what we've figured out is that one person can be making those decisions. It's better when there's a group, and the group comes from different aspects of the issue. So community partners, government, ethicists, doctors, nurses. That's how we make better decisions. And what are the principles of bioethics? I think I've pulled out the standard medical student 4 principles of bioethics. 2 of them jump out at me in terms of shortage and of COVID vaccination. But let's look at them. Autonomy. Each person has the right to decide what happens to their body. Beneficence. We do our best to reach the best outcome for each patient. The third one, minimize harm. That good old Hippocratic oath of do no harm. And finally, justice. Aim for even access across all groups. Well, when we don't have enough, we're not going to get that. We're not going to get even distribution of a shortage drug. When this is not possible, to distribute scarce healthcare resources to maximize good. So keep that in mind. Next slide. Okay, so I said I would have 5 reasons to vaccinate teachers. Let's go through them. First, school workers are vulnerable, and our vaccines have been shown to save lives. So the teachers and janitors and administrators, they and their loved ones are at risk of death and severe disease. They're pretty much by definition adults. This pandemic has hurt adults worse than other age groups. The CDC says that 47% of US adults have 1 or more major risk factors for severe COVID, like high blood pressure, or diabetes, or obesity, or heart disease, or lung disease. They may be also caregivers themselves, their own families, their relatives, maybe in the same household, maybe in separate households. We have to admit that our screening for COVID is attempts to be good, but it can be imperfect. It can miss people by symptoms and by frequent testing, and frequent testing is expensive. So screening is imperfect. So there can be exposure to people who have COVID. And mitigation factors may be imperfect in various school settings and various home settings and various community settings. And you know those mitigation factors very well. So they're at risk, and our vaccines work. The first 2, the FDA approved ones, are 95% or 94% efficacious to prevent symptomatic disease. And here's something interesting. Early evidence suggests that AstraZeneca and Pfizer may prevent hospitalizations as early as 28 to 34 days after the first dose. So maybe really in that first month-ish after the first dose, people are starting to have revved up immune systems to protect themselves. Now that evidence needs to be strengthened, and we need to find out whether that's true for the other vaccines, and also for our, really show it in larger studies. But this is kind of intriguing early evidence. Next slide. More on vulnerability. What do we know about household transmission? Well, children and adolescents may be less susceptible to infection, but they might be more infectious than older persons. That can be debated, and you can look at different studies, but there is concern about the infectiousness of children, and that varies across age groups. So we need to learn more about this brand new pandemic. Something interesting too is the difference between pre-symptomatic cases and asymptomatic cases. If you have two individuals who have no symptoms of infection, one might be very infectious because they've already got the virus, and in a week they're going to have symptoms. That person very infectious, but they may look identical on Monday morning as the asymptomatic carrier, the person who has a little bit of virus in their nose and throat, and they look the same. They're healthy. They're back at school. Okay, so that's an issue. Pre-symptomatic could be highly infectious. Asymptomatic, probably not very infectious at all, but they look the same, no symptoms. That's one of the quandaries. That's kind of the lingering thing that keeps me awake a little bit at night. Next slide. So this second issue about promoting teacher vaccination is that the CDC has a neat recent study that suggests that teachers themselves might be key transmitters. So this was a study looking back at who got exposed, who got symptoms, who got disease, either symptomatic or asymptomatic, in a single Georgia school district. It was elementary school. This is your K-12 group. And what they studied was, if there were outbreaks, what was going on? Where did it come from? And they were able to pin down that 15 of the 31 cases were associated with either teacher-to-teacher spread, and then or teacher-to-student spread. So the kind of the source was the teacher. So what else was going on in these classrooms? Well, they looked a little bit. They dug in and they said, well, the average outbreak was 6. They're kind of small, and they were trying to do mitigation factors. They were trying to wear masks, but there were instances when people didn't wear masks. And they also weren't able to keep 6 feet away. They were trying plastic between as barriers every 3 feet away. So when imperfect mitigation happened, there was the potential for these mini outbreaks. This is just one MMWR little study in one district. And there's lots of studies building that suggest that school isn't a primary source of infection. But it does tell you that transmissions can happen, and mitigation may not always be perfect. Okay, next slide. So we talked about students at risk, teachers at risk. What about the impact of vaccination? What does it really do? Well, there's some suggestion that the viral load within the nose and the mouth, where the virus reproduces, right, drops dramatically after vaccination. This is fantastic news. It's getting at that message of, okay, are they going to not carry the virus after vaccination? And it's sounding like this effect happens early post first dose. So let's look at this a little bit more. It's a new study, hasn't been peer reviewed, new publication, happened in Israel, which is by now it's our most vaccinated country. And what they were able to measure was that the viral load of people who are vaccinated dropped fourfold within the first 12 to 28 days of the vaccination. So I'm encouraged, but the whole story isn't out yet. We counter that with knowing that this virus spreads in tight situations, when people shout, when people sing, when people are in close quarters and people are touching. We know all this. We also know a little bit about viral load. What is viral load? When I talk to my HIV patients, I say, well, in a drop of blood, the viral load is how many virus particles are in there, in the concentration. And we know that we're very excited to be able to say that when you drop that to undetectable levels for HIV in the blood, totally different process, right? That sexual transmission goes down to 0. And this is really exciting. And so this is an intriguing idea that if we drop the amount of virus in the nasopharynx, maybe there'll be less transmission. Next slide. One of our hopes will be that vaccination will reduce that infection rate and will get us to herd immunity. You probably have talked about this in other group settings, but this is a really wonderful diagram that just kind of lives for me. It explains herd immunity. Let's look at A, where there's an unvaccinated population, and say I'm that blue spot in the middle, and so I'm a vulnerable host. If I'm in a room that's unvaccinated, I could get it from any of those red dots. Okay, there's plenty of room that could expose me. The red dots are people who are infected. And then as we gradually improve the vaccination rate, there's going to be times when I, as a vulnerable host, might be in close quarters with people who are infected, but there'll be less chance that an infected person hits me. And then ultimately, when I'm vaccinated, now I have immunity. I'm a blue dot, and when I get exposed to somebody, not only do I block that infection, but it doesn't spread to others. There's no downstream infection. But we're not there yet. We don't have data yet, but we're aiming for herd immunity. Next slide. Oh, so number 5. Well, that's a little bit of a toughy one, a tough topic. What about fairness? What about justice? So one of the things that I hear from teachers is they didn't sign up for this to be frontline workers, essential workers in an area, a region where there might be more exposure to COVID. So compare that young teacher who signs up to be a teacher and might be having different feelings about risking their life compared to somebody who signs up for the military, who signs up to be a nurse in an emergency room. They may come in with different expectations. And the words I just used, I used feels, expects, plans, visualizes. These are, feelings and concepts that have to deal with what the teachers are experiencing. And when they get together, they're a force to contend with. What are their feelings about working in an area or back at school without being vaccinated, without having protection? And that's part of what your group is dealing with as well. I love what President Biden said a week ago. He was mourning 500,000 US dead. Each one of these people matters. And in fact, each one of our teachers matters. Each one of our lives matters. Every one of our lives matters. And so part of this is they didn't sign up for this, but the fact of the matter is none of us signed up for a pandemic. None of us expected this. But perhaps some of us are able to protect ourselves by, by sequestering ourselves like Prospero in the Abbey. Next slide. Next slide. Thank you.
Yeah, there it is.
Yeah. So this is actually the 6th reason to vaccinate teachers is one of my favorites. I think coming from Chicago, part of it is that our teachers represent a wonderful, wonderful resource of good example. Our teachers are leaders in our community. They can help fight vaccine hesitancy because they're embedded in our local communities. They can fight misinformation. They can prove to be our best educators of parents, of children, of our communities. What does the CDC say? Why get vaccinated? To protect yourself, to protect coworkers, your patients, your family, your community. It all starts with you. And I think we're highly aware of healthcare disparities, that there has been not equal access among our Black and Brown communities, and that we need to reach out to them with voices that they trust. And I think that our teachers can be part of that source of role models. Hey, I got my vaccine. I did all right. I feel better for it. That's an important message. Next slide. Okay. So one last little point is, does time matter? How rapidly do these vaccines really protect? We have hints, just hints of early disease or early studies that tell us that maybe even within a few weeks of the first dose of our 2-dose vaccines, that people are being protected and that their immune systems are being revved up. And I think that that's a wonderful tool that we have to emphasize vaccination as quickly as you can when you're chosen, when you've been told that you can get a vaccine, take it as quickly as you can, because I think there really is a rush against time. If anything that we can do to reduce mutants that might evade our vaccine, the real key is to vaccinate as many people as we can. Next slide. Okay. So last, just to touch on a couple of things, and that is why vaccinate children. We need to protect the children. There are tiny numbers of severe disease with viral pneumonia, mainly in little ones less than 4 years old. And there's this very rare severe disease that happens after COVID infection, perhaps weeks later, that multi-system inflammatory syndrome of children, MIS-C. We've also seen a handful of cases in adults as well. We also know that children can be spreaders of COVID, but typically have milder disease. But the key to getting back to our normal is to vaccinate the world, and that includes our children. Next slide. So what does the news say? What do we know about vaccinating children? Dr. Anthony Fauci said that he's hopeful that we'll have that vaccination information and be ready to vaccinate children in late spring or summer. Wonderful. Will the data be available about safety and efficacy? Well, Pfizer's already enrolled and their results aren't available yet, but we need to find out what is the right dose for the right age, and is it as safe as the adult versions, and is it safe in children? And we have to figure that out. And the Moderna vaccine is right behind in recruiting their vaccination studies. So we're on our way to getting these answers. As I said in the beginning, this story is unfolding and all of our information is not available yet. Okay. With that, so we've covered a lot of area and it's now time really for question and answer. I think there are some issues that I've talked about today, and I'm sure you have questions, and I haven't been able to read the chat, so we'll cover some of that. Next slide. I do know that the themes that when I think about controlling COVID, I think about altering space and time and behavior. And I'm not sure that vaccines exactly have impact on space. That's your job when you're looking at each school. But in terms of time, I think we can think about when to vaccinate teachers and should it be a requirement to back to school or not. I know what the CDC has said and said if mitigation is okay and there isn't that much virus in your community, go ahead and open before vaccination. But this is part of the equation that I'm hoping you're going to use some of the information that I've given you when you're thinking about this as well. And then in behavior, what about using those teachers as our communicators to really help expand vaccination access, because more people may agree to vaccination once they've heard their own teacher or their child's teacher has gotten vaccination. And I think with that, I think we're ready for comments and questions.
Great. Thank you, Sarah. You know, so some of the questions I'll get through from the chat box, and you know, some of our folks here are in areas where school reopening is being mandated from on high. Some of it's where there's just a lot of pressure, and you know, we're seeing some data where, you know, hey, hearing that, hey, as long as you're putting these mitigation measures in place, schools don't seem to be spreading events except in cases when there isn't compliance. Like the one you showed in Georgia, you know, the spreading there seemed to be due to a lack of compliance on mask wearing and that kind of thing. And so there is obviously been building, and there are a lot of pressure on reopening. And just thinking about the vaccination as an a priori to opening, one of the key questions is, can you give us your thoughts on that? You know, obviously there's a lot of considerations that have to go into place there, but on vaccinating teachers as a prerequisite to opening, is that something that you think, how would you think about that? Would you think about that as all adults, all kids and adults, some adults, and based upon the data that you're seeing, how would you help us think about, you know, this prioritization of vaccination before reopening? Is it all or nothing, or are there some nuances there?
Yeah. Well, I'm a firm believer that our CDC is having to take and synthesize this information and are really our guides. The CDC has gotten some bad press because the messaging changed. Well, this is brand new pandemic. We were learning and we continue to learn. For me to give a blanket statement beyond what I've said for every school district, every state, I think would be wrong. And I want to align myself with the Centers for Disease Control.
Okay.
What are they saying? They're saying it's not a requirement because they, you know, when there's a shortage, it's really hard to say, well, gosh, just don't do it. And
Mhm.
they're saying a qualified, if mitigation measures can be in place, and if the density of the disease in the community is low enough to safely do it, it can happen. And they're
Mhm.
saying it can happen.
Mhm.
So could I cherry pick certain people who should get the vaccine among teachers? Well, it would be the people who are most at risk. And those are the people at this point in time who might be saying, I have to step back from in-person teaching because I'm too much at risk. And that, if you want to get them back into the classroom, then the people who have obvious severe risk for COVID, those would be the people who would be first on the list.
Mhm.
How to operationalize that is pretty challenging in our, in fairly unorganized way of getting vaccine to people.
Mhm.
I suppose if school districts themselves got a portion of vaccine and were able to decide which teachers in their group were most deserving, that would probably put them in a tough position, but you might be able to get more of those teachers back into the classroom quicker.
Okay, so one of the questions that came up in the chat was about vaccine effect on children. You know, given that I meant children aren't first in line for this, um, given what you've seen, we don't have a large data set, but given what you've seen on the preliminary trials and of these different vaccines, has there been research on and studies on the effects of these vaccines on children? Were children used as part of? I doubt it. Right, it's part of the studies, and that's a kind of an open question. I don't know have
Yeah,
any relation to that.
yeah. So the Pfizer vaccine is fully enrolled and they're gathering data. So they probably have some data on safety within the first week after vaccination, which is probably the most critical. I don't have that available to me. I'm not sure any people outside of the company do, and
Yeah.
outside of the people who are doing the trials. But there is some potential for a secondary benefit with less COVID around and perhaps less transmission. But that also is data that's being created now. It's like we're gonna figure it out if there's really a lot of reduced transmission once our adult population is better vaccinated.
A lot of the conversation that we've been having, to sort of contextualize it, back in spring of last year, we were talking about um, hydrogen peroxide sprayers and cleaning services and bleach, and it was very much a surface fomite transmission vector that people were concerned about, and we talked a lot about, and modeling costs and so forth. And obviously that's shifted, and now
Yeah.
last week we had a great conversation with an industrial hygienist who's been a regular part of our conversations, David Lipton, about cleaning versus disinfecting and so forth on that topic, which is always going to be a part of the mix in a response, short and long term. But the airborne virus, the airborne threat, is that invisible enemy, as you opened with Poe. From as you look at infectious diseases, prior to COVID, and in your experience, just studying these things in pandemics, um, what kind of lessons can you share from studying pandemics past, and what how we've responded to them? Is there some corollaries in history of infectious disease events like this that you can say, I wish people would know X, Y, Z about effective responses to these outbreaks in the past, and not repeat the same mistakes we always make. And I'm speaking in broad terms because I don't know, but what I do know is an amateur crack historian is that we have a big tendency to overreact and pendulum swing after the latest event, to the point of creating other problems, and it takes some time for us to find our middle ground. So with that meandering, broad, and probably not very helpful question, could you give us a little bit of historical context that we should know as we look to respond to this?
Yeah, yeah. Well, I think we can look back 100 years to the 1918 influenza pandemic, which has a lot of parallels. We can think that, well, people 100 years ago, they're pretty much like we were, and they respond with fear and try to alter their lives by staying inside and not going out. And when the fear happens, everybody's trying to do the right thing and wearing masks. And then something happens when they think the fear lifts, and people have a tendency to go wild. I think that's perhaps why we had the Roaring '20s in part. So there were waves of virus that happened. There were swells, and then times when there wasn't any of the influenza, and then it would show up somewhere else, and then we wouldn't have any, and then it would show up somewhere else. So one of the things is this did not surprise people that we were going to have a winter rise in COVID infection. We anticipated it. Everyone did. We thought, well, respiratory viruses, they always heat up in the winter, and we're going to have it. And lo and behold, we did. So that was the first lesson, that a lot of respiratory viruses do exactly this. But back to the flu, of the 1918 flu, there are some classic cases when other events happen and people decide to gather despite having the virus around. The classic example happened in at the end of World War I in Philadelphia. The city of Philadelphia decided to have a big parade to celebrate the end of the war. People were absolutely jubilant and joyful, and they wanted to be together, and they wanted to scream and shout, right? And so they did. And then that virus causes symptoms within 48 hours. It transmits, you get shaking chills and high fever and a cough and a bad headache, all within 2 days. That's its time frame. Unlike COVID, which is more like symptoms maybe percolate for a week or so. So they counted the deaths that happened after this one parade. They could say, these deaths happened because we gathered, we let our guard down. So that's sobering. And there are other instances in history like that, because human nature is that we can only hang on so long, when we can only restrict our socialness so long before we want to break out.
And that wave of winter spike for infectious disease, is that for a novice, is that tied just to being in indoor spaces because it's cold? Is that it, or is there something else?
And That's always been kind of the theory, but it happens, around the world when it's winter and there's a wide range of temperatures and humidity and different circumstances throughout our world, throughout our planet. So that's what we say, and we're actually not quite so sure. The one saving grace of COVID is we haven't had bad influenza this year. And I think that's in part because of the mitigation for COVID also mitigates flu, and it's just better at preventing flu. We were happy to hear that at the other hemisphere, the southern hemisphere, their influenza last 6 months ago had been mild, and then lo and behold, here in the northern hemisphere, it's been true as well. So that was the saving grace.
We're getting close to time. Is there anybody that has particular comments, questions for Dr. Sutton that you'd like to share? Feel free to unmute. Well, talk over me, anybody, if you are so moved.
So, Sarah, we're in the, we have just been announced out here that we're quote unquote in the blue zone now. And I know the dials are varied across states. So when we start thinking about being in the blue, and we are with the protocols for Colorado Department of Health, which may be different from CDC, how as policymakers should we be thinking about the tying of the efficacy of the vaccine with meeting the CDC and / now the Colorado Department of Health saying it's blue, you can go back into school, as well as then honoring what you've been talking about, the timing for teachers, because blue suggests, hey, we don't necessarily need to have everybody vaccinated. We're good. Just the facing teachers, the ones that have direct contact with the students, and that's adequate. What should we be thinking about differently?
I think getting our teachers and support staff vaccinated as quickly as possible is doable. It's particularly going to be doable when we have our third vaccination available, and sooner is better. Sooner saves lives. So
Can we go back with one shot? Do we have to have the two?
That's the earliest evidence is suggesting that, and it's not proven yet, but it's suggesting that. This is exciting new news that I wanted to share with you, and I think it's going to it's going to unfold, and I'll be able to be more definitive about it when the data is available. But it's suggesting viral loads in the nasopharynx is lower within a couple weeks or 3 weeks of the vaccination, and that's super encouraging. That means the person's immune system is fighting back and decreasing replication of the virus in the source, in the respiratory cells of that human.
Thank you.
Sure.
Maybe leave you with this parting question. So as an occupational hazard, in much of the folks in this line of work, we can't look at a school without assessing possible roof damage and looking at measuring capacity and all, you constantly, and I imagine for you, you see germs everywhere, right? The sixth sense kind of thing. What lesson have you wanted, schools, other places that run lots of people through indoor spaces all the time. What are sort of the general lessons for preventing infectious disease spread that you would just like people to adopt? I'm thinking a year or two from now, this is another influenza-like virus that we're just living with, but we vaccinated against, and we don't like it, but it's not causing the world to stop like it is right now. And we're moving forward. But what should we be doing better in schools, just to prevent what we all know as parents is, oh gosh, it's Labor Day. Everybody's going to be sick now in my house because my kids are going back to school. Like, what are the things that we should be doing better, generally speaking, from your perspective as an infectious disease expert, that we could learn from this and sustain for the long haul to help prevent these kinds of events?
Right. A really good question, David. What I've experienced is that knowing what reduces transmission and making it happen in whatever group setting you're in are two different things. Knowing that washing your hands helps prevent infection, and having that alcohol rub at your fingertips and bringing it out and sharing it with your family at dinner time doesn't happen all the time, but it could. Teaching children that, after the bathroom, you wash your hands. This is how you could safely do it, and model it. That's the kind of thing that's going to help us reduce the amount of respiratory viruses. Making sure that vaccination is accepted and we dispel the myth of vaccination. We've fought and conquered many childhood illnesses. We've stopped all worldwide smallpox through vaccination. We've almost stopped all polio. These are incredible advances through science. And I think we have to create really an atmosphere of really having a counter message to anti-vaccination.
To the misinformation.
Misinformation.
Calling it what it is, yeah.
Right, and using our role models, yeah.
So there's a bit of the everything I ever need to know I learned in kindergarten. Wash your hands. As well as a sort of pedagogical push of, hey, we should be teaching about these events. We should be talking about them amongst all of the other things that teachers have to do, of course.
Well, and families, you learn a lot at home, and good role modeling of basic hygiene will help. Washing your hands, covering your mouth when you sneeze. We may even in the future in crowds be wearing masks, 5 years from now, or in the winter wearing masks. I don't know. I don't have a crystal ball to that, but that may be part of our future to reduce influenza. It's almost zero here in Chicago. That's just amazing. And perhaps our vulnerable hosts certainly should be considering that.
Well, yeah, that's the long-term
Yep.
is certainly an open question at the moment. Well, I want to thank you for your time and your preparation for this presentation and for your answering the questions. And folks, please thank Dr. Sutton on your way out in the chat or however you wish. And if you'd like to, and Barbara, your comment, that's actually an interesting one on masks. There's quite a variance across that in different cultures around the world, and we've been the cavalier ones.
Yes, we have. Yeah. Yeah, very good. Well,
All right.
thanks everyone for working on this big problem, and my best to all of you.
Thank you, Dr. Sutton. Thank you, everybody. Have a great day.